And our last speaker before we open it up to questions is Bob Wiggins. Bob will be discussing a summary of physicians' ability to use the IRIS registry.
Thank you. There it is. Good afternoon. So I'm going to look at IRIS a little bit through the perspective of practice management. So we ask, who doesn't want quality? Well, we all want quality. The patients want it, physicians want it, government wants it, our payers want it. So why is everybody grumbling about improving quality? Well, it's not improving quality, it's reporting on quality that's causing all the grumbling. And this is a study you heard about in the session yesterday afternoon, just published in Health Affairs, that gets to this issue about the fact that they looked across a broad range of specialties and found that staff and physicians were spending on average 15 hours a week reporting on these measures. And it's not just the ones we think about, PQRS and EHR meaningful use, but other payers have multiple measures. Hospital systems have measures that doctors are reporting on, and there are hundreds and hundreds of these measures out there that physicians are reporting on that aren't terribly well coordinated between these different groups. And it turned out that they estimated about $15 billion annually was spent on reporting on these quality measures, worked out to about $40,000 per FTE physician. And over 80% of physicians in this study said in the last few years they are reporting on even more quality measures, and yet less than 30% felt it was actually improving the quality of care. So, toll on time and money there. The next one is the emotional toll on physicians. This was also alluded to yesterday. All of the extra documentation that's required with our electronic health records, including reporting on quality, has been attributed to leading to burnout. And if you look at some of the top areas on the list here from this survey as what's contributing to burnout, a lot of these can be directly attributed to our computers and all of the documentation that's required. And then finally, if that weren't enough, because of all the extra documentation required, and I've just talked to several of you this morning that are just converting to electronic health records about how you've had to cut back your schedule and patient complaints are going up and wait times are going up. Well, wait time is negatively correlated, as you might imagine, with physician scores on the CAHPS survey, but it taints the whole picture of quality of care that the patient is experiencing. So when they report on the quality of information that the doctor provided or the staff provided, or the instructions that were provided, or the overall experience of their care, long wait times correlated with negative scores on all of these measures. So the very thing we're trying to improve quality is actually a detriment to quality from the eyes of the patient. And so I'm going to go through you and just show you really how marvelous an innovation IRIS has been in our practice, and just take you back through our history of quality reporting. We've been reporting our practice, Asheville Eye Associates, from the very beginning. It used to be called PQRI and it's now PQRS. But there were three measures to report on, and these were, what people say the good old days, paper, right? So we had our electronic health record, but we were reporting all this on paper on our claims forms, and we'd ask the technician at the end of the exam and make sure you circle those codes at the end of the exam that we actually completed these measures. And so down there at the bottom you can see where they've circled. And these were our results. So in the first year, that's all we had to do was circle the chart that we did it, or that we didn't do it. We just had to make a circle. About half of our physicians qualified for the payment. And then you look in 2008, and 1 out of 14 physicians qualified with this process. And you say, talk about knuckleheads. They said, Wiggins, what is going on, with this. We got 50% this year, and we only got 1 the next year. And the reason being, if you recall, is you didn't get your report on how you did in the first year until well into the second year of reporting. And so by the time we got 2007's report, we were almost through 2008. So talk about anything but real time. This is not real time data we were getting. So by the end of 2008, we figured, no, we've got a problem here. So in 2009, we saw the lousy results from 2008. You can see by 2010, we finally had this paper process figured out. 4 years. So the next phase was an improvement. We were now filing electronically through claims, and our vendor was helpful, and they now had highlighted in yellow, okay, you've got a PQRS measure here, so you better pay attention to this one. So that was an improvement over the paper where we didn't have that visual reminder. But then, as you can see, there were 9 clicks you had to go through. And remember, you had 3 quality measures then. So 9 clicks to finally get through and document that you had met this measure. And you can see this was highly successful. We were 100%. I can tell you, though, when our administrator and I presented this data year by year and the dollars we had gotten in incentive payments, if the physicians had had any tomatoes in the room, they would have all been aimed directly at the 2 of us. And they say, what are you talking about? This is a success. This has been absolutely horrible. It's terribly impacted workflow. Our patients are waiting longer. Everybody's unhappy. The 9 clicks to get through every one of these measures, we just as soon forget PQRS, even though we're meeting all the measures. And so then, help finally on the way. By 2014, we'd come on with IRIS and have been using this to report on these quality measures for the last 2 years. And as you can see, once the mapping is done, there's a little bit of time involved on the front end, but less so the more people that are using your vendor come on. Your time for reporting goes down to 0. And the grumbling goes down. In fact, I think our physicians have even forgotten these programs are out there because they just don't see them anymore. It's all happening in the background in terms of what they have to do to report. And so here we are. As George mentioned, you can get real-time data, so 100% success rate. And if you know a little bit about me, you know I'm a big believer in lean healthcare, and you want to talk about taking lean healthcare to the max, taking these horrible processes that we've had in place and converting it to something where the physicians and staff no longer even recognize that this data is being collected. And so to get back to quality, we all know we have to have the data to improve quality. What gets improved is what's measured. And Dr. Weinstein has said here that we know more about what's in a cereal box than what's in our healthcare system. And we're collecting the data to help us improve that quality. So what's the IRIS registry about? It's working on measures that directly contribute to patient care in a way that doesn't impact workflow, and which leads to improved patient and doctor satisfaction. And IRIS is actually already measuring patient satisfaction, reporting on the cataract measures, and we're looking at ways to do that. Depending on what happens with MIPS and what they're looking for on quality reporting, it's something we're looking at that IRIS could report on that as well. So where are we now? We're just in the process of mapping the new subspecialty data measures in the practice. I'm particularly interested in doing pediatrics at the pediatric measures. These are developed in conjunction with the subspecialty societies. So we have 2 pediatric measures here. I'm very interested in seeing what's going to come of this. I've had a little preview in participating with the Part 4 of MOC, the Quality Improvement section, and I chose amblyopia as the measure. As you know, if you've done it, it's a fairly tedious process, and the ABO is working on streamlining that, and in fact, working with IRIS. And I can tell you from that little insight into my data, and I was having to look for just a few charts to get follow-up on, and how many charts I had to go through to find patients that actually returned enough for follow-up to include them in the data set. It's amazing how many numbers of patients had not shown for follow-up or dropped out of the system, and I think we're going to see this very easily with IRIS. You'll notice these are also looking more at outcome rather than process measures, and that's intentional. Process measures tend to be met fairly easily. Outcomes take a little bit longer. And then finally, I read something coming up here, an email that said that something to the effect of that we are the lost generation of physicians, that we're doing all this work, all this massive change that's going on just so we can benefit the next generation of physicians that's going into healthcare to work out all the kinks. Well, I don't think it's all that bleak. I see the glass as more than half full here, and I really see, just like we were shown here, that we're going to have this data at our fingertips, not just from IRIS, but from our EHR and from our practice management system. And I think we're going to have this dashboard that we can go to and get real-time data. How many patients did we see in the clinic that day? What's our days and AR doing? What's our efficiency? We're going to be able to look right away and say, what was the average wait time by doctor in the clinic that day? What are our patient satisfaction scores for that day? And then IRIS inputting data on quality metrics, and then cost, as Bill alluded to yesterday, looking at bundles of care. So I think it's an exciting time to be in medicine. Thanks.